Thank you. It's going to start with a review of what disorders of consciousness are. And this will be a counterpoint for our discussion this afternoon about brain death and the definition of death. I'm going to highlight the talk today on some of the newer research showing that some patients thought to be unresponsive and unaware may have awareness. And I want to focus on how that information should be translated into the diagnosis and prognosis, communication, decision-making, and treatment of patients with this type of disorders of consciousness. These are the disorders of consciousness that I'm going to be talking about. First of all, coma, which is there to understand this, and I know in the audience are some people who have a lot of sophistication in this area and others who don't, so forgive me for some of the background here, but coma has two dimensions. That is, consciousness has two dimensions, and that is wakefulness and awareness. Both of them must be absent in coma. Wakefulness meaning the ability of the person to open eyes to stimulation and have readiness. Awareness of self and environment is the second dimension. In coma, both of those are lost. The vegetative state, on the other hand, has wakefulness but not awareness. And this has recently been a new word of unresponsive wakefulness syndrome has been offered by Stephen Lauries from the University of Liège. But most of the time, these are referred to as vegetative state. Minimally conscious state is a somewhat less severe form of a disorder of consciousness where patients are intermittently aware, but not constantly. Brain death, which we'll be talking about this afternoon, is the complete cessation of all brain functions that can be tested at the bedside. And then the locked-in syndrome, which we are not going to be discussing today because it is not a disorder of conscience, but rather a state of severe paralysis, but retained wakefulness and awareness is going to be the subject of an ICREA meeting later this week, hosted by Fernando Vidal. And the locked-in syndrome is useful to contrast because although it is not a disorder of consciousness, it can be mistaken for one. Now, this is a graph that I produced that I think helps understand these different clinical syndromes where they're being explored in two dimensions. On the vertical axis is cognitive function, going from unawake and unaware to normal. And on the horizontal axis is motor function, going from absent up to voluntary. And then this is a way to diagram where these different syndromes are. So for brain death, there is absent motor function and absent cognitive function. And a normal on the other end of the graph is voluntary motor function and normal cognitive function. A coma is unaware and unawake. Both dimensions of consciousness are absent. And the reflex motor function such that there is purely reflex. In the vegetative state, the patients are unaware but awake and have complex motor function, although not voluntary. In the minimally conscious state, there's purposeful movement and fairly normal. Then the locked-in syndrome up here has normal cognitive function, but very abnormal motor function. It's a state of voluntary paralysis, although there may be movements of the eyelids or the eyes. So anyway, that's up there. And this, I think, is a useful way to conceptualize some of these different disorders. Now, let me say a few words about the vegetative state, and this will be the subject of the panel discussion following my talk. And these criteria that were elaborated are clinical criteria that neurologists at the bedside can determine and were proposed by the Multi-Society Task Force on the vegetative state, in which I participated as one of 10 panelists representing the American Academy of Neurology. And our result, our paper was published in the New England Journal of Medicine in a 2-part article in 1994. And these are the criteria that we arrived at, and they've been generally accepted, I think. Unawareness of self and environment, no sustained, reproducible, purposeful, voluntary behavioral response to visual, auditory, tactile, or noxious stimuli, no language comprehension or expression, persistent sleep-wake cycles, and preserved autonomic and hypothalamic function. So patients treated, young people particularly, can survive for long periods of time with adequate medical and nursing care and preserve cranial nerve reflexes. Most of these people in a vegetative state, recall, who are unaware but awake, have intact brainstem and hypothalamic functioning and are missing thalamic and cortical function. About 10 years ago, I published an article in The Lancet looking at, there's an update really on what is known about the vegetative state. And I had a graph of the behavioral repertoire of such patients. And these are some things that the patient is capable of doing. The patient is not capable of the other things, but is capable of sleeping, yawning, breathing, having sleep-wake cycles, blinking and moving eyes, but no sustained visual pursuit. That is, seeing if the person can follow something around the room, cannot do that. Make sounds but no words, variable response to visual threat, coming at the eyes and seeing if there's a blink, grimacing and chewing movements, and moving the limbs. So those can be done. The diagnosis of the vegetative state is fulfilling the diagnostic criteria, which, as I explained, are principally negative criteria. That is, what a person cannot do. And as a member of the group that came up with this, I think if we had to do it again, we might want to do something slightly different, because when one determines diagnostic criteria as negatives, it invites the opportunity for a false negative diagnosis. And that's quite common in this disorder, unfortunately, because there may be reasons other than the brain damage that people cannot do certain things. Maybe there's toxicity of medications, for example. But one of the things we also do is have patients look at themselves with a hand mirror and see if there's any glimmer of recognition when they see their images. Interview nurses and caregivers to see if they have seen anything that suggests consciousness. But despite that, there's a false positive rate of 40%. Namely, studies have shown that the doctors misdiagnose it, overdiagnose it, when the person should be in minimally conscious state, which I'm going to talk about now. This is a less severe form of a similar injury, because the spectrum of global brain injury is a continuum, and our clinical syndromes erect barriers separating the clinical syndromes somewhat arbitrarily. So there's a range of disorders even within a given clinical syndrome. But in any event, this has been defined as a condition of altered consciousness in which minimal but definite behavioral evidence of self or environmental awareness is demonstrated. And such patients may be able to follow simple commands, gesture yes/no answers, make intelligible verbalization, reach and touch objects presented to them, sustain visual pursuit, or smile or cry appropriately. Or they may do one of these but not the others, or they may do them intermittently. So if a person can do any of these at all, they're not in a vegetative state, because these require awareness. So they don't have to have the full panoply of these abilities, but whether they can do any single one of them. Now, let me shift now from the clinical diagnostic criteria to some of the studies that have been done recently that show that our diagnostic criteria are not perfect, and that a small subset of patients diagnosed in the vegetative state are probably misdiagnosed because they have awareness, but we just can't measure it. Now, if one looks at the different types of studies that are done, there are things involving positron emission tomography, or PET, which is a functional test looking at the metabolism of brain neurons, functional magnetic resonance imaging, or fMRI, and this small subset has been shown to have covert cognition, and some PET studies have shown the same thing, using fluorodeoxyglucose, which is the FDG in the abbreviation. And then there are studies looking at the electrical output of the brain, electroencephalography or EEG, and evoked potentials, also studies. The old studies, and I make a distinction between new and old, it's about 10 years. The older studies showed a reduction. If you take someone in a vegetative state, the baseline brain metabolism is markedly depressed, not surprisingly. And that's measured this regional cerebral metabolic rate of glucose consumption, which is a measure of brain neuronal metabolism. And then a second set of studies was done, not just looking at the baseline, but stimulating the person and seeing if the stimulation could evoke an increase in local metabolism. So it could be a visual stimulus or an auditory or a somaesthetic stimulus. And these showed that, yes, indeed, there was some evoked increase in focal brain metabolism only to certain areas, but it didn't induce distributed connections, which are required for awareness. And Steve Lauries, who's one of the experts in this area, in an article, said that the best way anatomically and functionally to conceptualize the vegetative state is that it's a cerebral disconnection syndrome. That cortex is disconnected from the thalamus, and it can be caused either by diffuse damage to the cortex, diffuse damage to the thalamus, or interruption of the white matter tracts connecting the cortex and the thalamus. And this was the state of the art until about 10 years ago. And Adrienne Owen, who at that time was at the University of Cambridge, published a short case report in Science in which kind of changed the spectrum here, and showing that not all patients diagnosed as vegetative were probably truly vegetative. And this case was a 23-year-old woman who his group examined 5 months after a traumatic brain injury, and skilled examiners diagnosed her as being in a vegetative state. Most of the problem with misdiagnosis of vegetative state is unskilled examiners who aren't examining people according to current standards. But that wasn't the problem here. They suspected that, for some reason, that she might have residual awareness, and they asked her to conduct some ideational activity. They asked her to think about playing tennis and thinking about serving a ball over the net and returning it over the net and so on. And then in a second series of experiments, they asked her to think about walking around her house and thinking about each room that she entered and what furniture she might see or what paintings on the wall and so on. In the tennis activity, it activated the supplementary motor cortex, and I'll show you the images that Adrienne Owen sent me. And then told to, in the walking around the house, this activated the parahippocampal gyri, posterior parietal lobe, and lateral premotor cortex. And importantly, it was analogous to the same experiment done in normal people. It's noteworthy, and I'll come back to this later, that she recovered 11 months later to the point of clinical evidence of awareness. That is, she was one of these people for whom the vegetative state was a transient state in the setting of spontaneous improvement after traumatic brain injury. So here are the images, and these are typical functional MRI images. And the way it works is that the patient's images are on the top, and the controls of normal people are on the bottom. And the tennis imagery is here, and the spatial navigation, that is walking around the house, ideas were there. And you can see on the patient that she's missing part of her skull up here because she had had a craniectomy to remove a large intracerebral hemorrhage after her head trauma. And the yellow areas are the areas of increased signal. And in the patient in the supplementary motor cortex, very similar to that in the normals, not quite as robust as in the normals, but I think it's convincing. And in the spatial navigation, these areas and the normal areas of 24 people whose findings were average are quite convincingly normal. So in this report in Science, he said that he thought that these data, even though they couldn't detect any evidence of awareness on their examination, by having her think about something and looking at the patterns of her thinking and then comparing it to the patterns in normals, that it suggested that she was aware. Now, this same type of paradigm has been repeated in many other cases since then. This is a summary of an article by Martin Mani, currently at UCLA, published in the New England Journal of Medicine in 2010, where 4 of their patients, and one of them was this one I just showed you, because Mani was part of the original study also, who were clinically diagnosed as vegetative state, could do what she did, and they termed it willful modulation of brain activity. That is, by a person's will, they could change the brain activity. Comparing that group of people to the ones who couldn't do it, and most of them didn't have this capacity because they were vegetative. Most of them had brain injury, traumatic brain injury from diffuse axonal injury, a very serious type of injury. The mean age was 28 years, and the time from injury varied, as shown. And one of the patients was able to communicate yes and no by varying these, thinking of tennis imagery for yes and the spatial orientation for no. And I'll come back to that when I talk about communication. Now, let me just say that the excitement generated by these data were not viewed by all as wonderful. And there have been a number of critics and skeptics of these data. The first was Alan Roper, a longstanding friend and colleague from Harvard, who wrote an editorial in the New England Journal to go along with Martin Mani's paper he entitled Cogito Ergo Sum by MRI. And you can read the rather clever thing he says at the end. But he was not necessarily convinced in saying that the mind is an emergent property of the brain and cannot be seen in images. In a somewhat more detailed criticism, Barden published a paper in Brain in 2011 trying to see how reproducible these findings were in a group of brain-injured people compared to a group of normals. And they were quite skeptical of this and said, they raised the question, had the investigators, and this quote is from their paper, conflated findings associated with willful consciousness with the actual occurrence of willful consciousness. Subtle difference, but an important difference. But they pointed out that there were technical hurdles to obtain consistent, reliable data using fMRI. Unlike ordinary MRI that looks at brain structure, functional MRI looks at brain function, and it requires sophisticated processing in order to generate these images. It isn't that you put the patient on one end and these images are generated out the other. It requires sophisticated processing, and that there are technical hurdles that must be overcome in order to achieve reliable data on which to draw firm conclusions, and those include inner examination variations and arousal state. Many of these people are up and down. One day they're a little higher, one day they're lower, and that's a problem. Motion, they may be moving around, and for MRI you have to hold entirely still. The effect of medication suppressing neuronal activity, and other variables that affect signal acquisition and analysis. In their control group of 14, they had perfect fMRI responses. But in their test group of 7 brain-injured people, they found a wide variation of fMRI responses to the mental imagery tasks and concluded that there were significant technical challenges to both designing and executing fMRI paradigms that categorically limit the conclusions. This is a study, it's not a study, it was a joke, really. It was done by a colleague of mine at Dartmouth, published in a journal of, it's not exactly humor, but it's satire, I guess, called Wired Science. And they took a dead whole salmon bought at a local grocery store, put it in the fMRI, and by adjusting the dials in just a certain way, were able to generate a signal which corresponded to the brain of this dead fish, just to show that we all must be skeptical just looking at a picture, because you have to know what generated that picture. What are the data? How are the data processed that led to that picture? In a more serious vein, this paper was published in the Proceedings of the National Academy of Sciences a few months ago, a very disturbing paper. And I admit I don't understand the paper because it involves an analysis of very sophisticated biostatistics. But what they basically showed, and the PNAS editors and reviewers must have thought it was valid, even though I can't tell, because they published it, and that they feel that a number of the fMRI studies, and there are thousands of these now published from psychology departments and so on, that when you're thinking about something, this is what your brain looks like, that many of those are fallacious, and that they have false positive rates because of errors in the signal analysis algorithms and statistical algorithms. So again, one needs to be a little bit cautious about immediately accepting all of these as valid data. This is a paper that Víctor and colleagues from Montreal published earlier this year in Brain, in which they outlined a series of ethical questions. And it's a typical ethics paper. I'm involved in clinical ethics, and I think we always say it's more important to raise the right questions than necessarily to know what the answers are. And that's what this paper did. They raised a lot of questions, ethical questions, for this type of research, such as, is this a therapeutic or non-therapeutic? That is it primarily a scientific endeavor, or is it therapeutic? Have the risks been minimized? Are the risks more than minimal if it's still non-therapeutic? How have the study participants been selected, and is it equitable? Have valid surrogate consent been obtained, and are there plans to share the results with physicians and family members? So things to think about in research of this. I want to summarize a whole series of studies, and I don't want to go into them in too much detail, but just touch on them. I think that the summary of functional neuroimaging by fMRI and the vegetative state have shown fairly conclusively that there's no integrated thalamocortical distributed networks from the thalamic intralaminar nuclei to the precuneus, that the central part of the cortex, or that's essential for awareness. There's no stimulation of the frontal parietal global workspace, and I'll show a picture of that next, and impaired backward connectivity from frontal to temporal cortices. So this is Barr's description of what he called the frontal parietal global workspace, and it involves large segments of the frontal and parietal lobes of the brain, as depicted in this old PET scan. The parietal being here, the frontal being here, and Coma showing this pattern, vegetative state here, sleep here, and general anesthesia here. And you'll see that sleep is an active state. It doesn't involve suppression of metabolism. Suppression of metabolism does occur in deep planes of general anesthesia, however, and those can mimic some of the vegetative states or coma. And I'll show some other MRIs in a moment that are a little clearer than this. This is Martin Monti's most recent review of the anatomy of covert cognition. He's very interested in what is it that's special about those people, that subset of people diagnosed clinically as vegetative, who are misdiagnosed and actually have so-called covert cognition. And in this study, they looked at 8 vegetative and 16 minimally conscious patients, and found in about half of them that they were able to activate the fMRI by various attention tasks, such as the ones that I showed earlier, and that what they're looking for is so-called top-down covert cognition, and that depends on thalamocortical connectivity. That is, the thalamus, thalami, and the cortex have to be connected. So that fits with our concept of vegetative state as a disconnection between the thalamus and the cortex. Now, more recently, FDG, that's fluorodeoxyglucose PET scanning, which is also a functional test, has been done. And it turns out that FDG PET is an even more sensitive way than functional MRI to look at the same thing. It isn't done as frequently in studies because there are many, many fewer FDG or PET scans because they require radioisotopes to be made on site, which is a very expensive device, whereas fMRI is considerably less expensive. So, for example, our psychology department at Dartmouth has their own fMRI machine outside the medical center used just for their studies, located in the college psychology department. They did a study asking the question, well, is FDG PET better or is fMRI better in this? And the answer was FDG PET was better. And they had 126 patients, 41 vegetative, 81 minimally conscious, 4 locked in. And they compared it to the CRS ratings scale. This is the Coma recovery scale revised, which is the best physical examination, neurological examination that can be done to assess the presence of awareness in an unresponsive patient. And then they did fMRIs and FDG PET scans on both. And they found that in minimally conscious state, the sensitivity was 93% using FDG PET, and the congruence with the clinical score was 85%. Whereas in fMRI, it was 45% and 63%. So you see it's lower. That if both were done, or either or both showed evidence of brain responsiveness in about a third of these patients. And this is what the FDG PET looks like. And the colors that are assigned, the code is red is good, blue is bad. So the blue areas have lowered metabolism. The red areas are more normal metabolism. So these are the minimally conscious state here on each side, and these are the unresponsive wakefulness syndrome, which is a synonym for vegetative state over there. So you see that the vegetative state people have much more depressed cortical function in the frontoparietal workspace than do the people in minimally responsive state. Not surprising, and correlates with the clinical findings. Now, I want to just mention briefly that in addition to functional neuroimaging by fMRI or PET, one can look at EEGs and evoked potentials. These measure the electrical output of brain neurons. So not just looking at brain metabolism, neuronal metabolism, but now looking at the actual output, electrical output through electroencephalography. And Cruz published a paper in Lancet 5 years ago in which he showed that EEG can be used in this way with a fair degree of sensitivity and specificity. There was some controversy about this paper, and a group of investigators wrote a detailed letter to the editor afterwards challenging the findings and saying that they were statistical artifacts, which the authors rejected, understandably. The next year they published this article in Neurology using the EEG paradigm and examining motor imagery tasks on MCS patients and showing consistent, robust responses in these patients. And that the Coma recovery scale findings, they found accurate in non-traumatic cases, but error in the traumatic cases. And 4 of the 44 disorders of consciousness patients had fMRI evidence of covert cognition. So this was about the same ratio that was seen in the neuroimaging, functional neuroimaging studies. And they advocated EEG because it's something that is available widely, whereas many centers, even those with MRI machines, don't have the setup to do this particular type of fMRI. But I think that this is still a little bit controversial. Evoked potentials similarly have been used, and these, for the people not familiar with them, are you would stimulate, say, a nerve in the arm or leg, and that stimulus would go up into the brain, and it would evoke a response in the brain. And by recording with surface electrodes over the skull, much like EEG electrodes, you can record a response that is evoked as a result of that stimulus. And these can be signal averaged, computer signal averaged and measured. And this investigators have found in non-traumatic vegetative state, the bilateral absence of the N20 somatosensory evoked potential correlated with lack of recovery of awareness, but it didn't correlate well in traumatic. And maybe that has some value also. And in a more recent paper published earlier this year, looking at somatosensory evoked potentials, SSEP, and this was the P3A wave, that it discriminated among 14 patients said to be in vegetative state, 8 of whom, or about half of whom, showed some evidence of bottom-up attention-orienting responses. I'm going to just skip over this because I don't want to take too much time. I did want to mention the minimally conscious state. There has been a very interesting and I think disturbing case, and the name of the patient is publicly available, and that's why I'm mentioning it, because it's in the public record. And this was published 10 years ago by Voss and colleagues from Cornell Medical Center, where I went to medical school. Is a patient who was in a minimally conscious state for 19 years after a severe traumatic brain injury with diffuse axonal injury. And he remained stable, more or less, for 19 years in a nursing home, and didn't talk, and made a modicum of responses. And after 19 years, he began to talk. And it was so striking that nobody could quite understand what was going on. He was sent up to New York and put through he was living in Arkansas in a nursing home. And in New York, they studied him, and they found, using not functional MRI, but diffusion tensor imaging, which is a way of using MRI to look at the axons, that he had developed axonal regrowth in the posterior parietal white matter. And they speculated that if the injury was purely a diffuse axonal injury and didn't involve destruction of brain neurons, that it could potentially improve if there were recovery of those axonal neurons. But 19 years is a pretty striking situation. But I think it adds humility to all of us that are called to the bedside to examine these patients. Now let me take some of these research data that I've just presented and try to incorporate them into what we do at the bedside. So to summarize, a few of the patients who fulfill the clinical criteria for the vegetative state show either fMRI or FDG PET evidence of awareness, or EEG or evoked potential. And I think that therefore they're not truly in a vegetative state, they're in a minimally conscious state. That they are not the usual reason for the high false positive rate of vegetative state. Usually that's from an inadequate examination and the delineation of the clinical criteria as negatives. And the question that it raises, and I wrote an editorial in JAMA Neurology a few years ago addressing this, was, should diagnostic criteria be expanded to include fMRI data? And that's what we'll talk about here very briefly. And the answer, I would say, would be probably yes, once they're validated. They're not yet validated. It's still a research tool. Now, what about the use of these data in prognosis, in addition to diagnosis? The old prognostic data, and these come from the Multi-Society Task Force report over 20 years ago now, was that if a patient had a neuronal damage that was not from head trauma, usually from hypoxic ischemic brain neuronal injury suffered during cardiac arrest, or stroke, or meningitis, or encephalitis, that if they remained totally without any evidence of awareness after 3 months, their probability of ever recovering awareness was very, very small. And the people with traumatic head injury, which has generally a better prognosis, we had to wait up to a year. Nevertheless, there were a few verified late recoveries, and since that time, there have been a number of other studies that have looked at this, and it turns out that the diagnostic criteria that we published years ago before the minimally conscious state was delineated as a clinical syndrome probably included patients with minimally conscious state, and therefore the prognostic prediction that the rules that we made, I think, were probably a bit pessimistic because of the inclusion of people with less severe forms of brain injury. And some of the more recent studies, none were as big as the databases that we reviewed, but I think show somewhat better prognosis. Now the question about the contribution of fMRI to prognosis. I mentioned when I presented the Adrienne Owen case that in their patient, she was on the road to recovery when her fMRI was done, showing responsiveness, or awareness, I mean. And she did develop clinical evidence of awareness later. And since then, there have been a number of other similar reports that the small subset of people who seem to have this covert awareness by functional imaging seem to also be the group that is going to get better. Almost all of them have been traumatic brain injury patients. Very, very few have been non-traumatic. So I think that that can be and probably will become important prognostically. This study by Stender that was in the Lancet 2 years ago, I mentioned earlier, comparing the sensitivity and specificity of FDG PET to fMRI, also showed that it was more useful prognostically as well as diagnostically. So I think where the FDG PET is available, it's probably better than the fMRI. Now I wanted to say a few words about the use of these responses to establish communication. And I might mention that this is relevant also in patients with locked-in syndrome and some other conditions to try to communicate. And that one of the Monty patients, the original, one of them, was taught to reliably communicate yes and no. And remember that in the Monty, this was the Adrian Owen thing, that what they did basically was they said to the patient, if the answer to the question is yes, think about playing tennis. And if the answer to the question I ask you is no, think about walking around the room. So they compared, that's how the responses occurred. And then they tried to validate them, asking the patient questions that they knew the answers to, like, is the name of your father Pierre, or whatever it was, the question. And they asked her a series of questions, some of which were true, yes, and some were no, and compared the ability of the patient to respond to other questions in those, and found over a 90% accuracy rate. So this has been possible, at least in that one case. What's interesting to me is that in all of the other cases that have been published in the past 10 years, no one else has had this capacity. And the reason is because there are many barriers to language function in severely brain injured patients. Many of them have aphasia, that is, the acquired loss of language ability from the brain injury. Many have global cognitive impairment because they have diffuse brain damage, like a dementia. They may be sedated from various medicines they're given, say anticonvulsant drugs treating seizures, or may have an encephalopathy from medical comorbidities. They may have heart failure or pulmonary failure or some other renal failure, so that there are many reasons that these functions would be suppressed. So even though the ability, it was exciting to see in one case, that has not been a routine ability. And those data pertain to the ability for medical decision making. And we like to have patient-centered medical decision making, where the patients are actively involved in providing consent about what will or what will not be done. And we always strive to do that in our capacitated patients. The willful modulation may allow people to participate, but I and others have been skeptical about using that solely as a justification to discontinue life-sustaining therapy when the person's only responses are yes and no. And I think that that's similar to what goes on in the locked-in syndrome, where people may respond with vertical eye movements or blinking or some other thing. A binary type of response where all you can do is say yes or no doesn't permit the full complexity and the nuance of conversation that is necessary before making a draconian decision about a patient, such as discontinuing life-sustaining therapy. And although we would want the patient to be included, I think one needs to be a little bit cautious about the primitive nature of this type of communication and reliance on that. The treatment of these people isn't the focus of my talk today, but just to mention it, in general, studies that have looked at treatment are more effective in the minimally conscious state than in the vegetative state. And most of the vegetative state ones, other than the use of amantadine, which was shown to improve some vegetative state people a little bit, don't really work. And that includes medications, electrical stimulation, whether it's deep brain stimulation, cortical, cranial, electrical, and magnetic stimulation. Those things, environmental stimuli with sounds and images and smells and so on, don't really help with the vegetative, but may help with minimally conscious. So the minimally conscious group, we tend to be very, very aggressive and trying rehabilitation and stimulation. And neurorehabilitation and palliative care are the hallmarks of treatment. In my book, Ethical Issues in Neurology, I discuss a lot of the medical ethical issues in the management of vegetative state patients, and I know that's going to be the subject of the next panel discussion, so I think I won't say too much about those, but I think that the role of the physician should be to try to state the diagnosis, prognosis, and the physician's level of certainty, because those are prerequisites for any kind of medical decision-making. It's important to try to identify patients' treatment preferences and work with a surrogate to implement them. And at least in the United States, it's common to involve hospital ethics committees to try to provide some oversight to this and make sure that things are being done properly and following guidelines. So to summarize my talk today about the impact of fMRI and FDG PET and disorders of consciousness, let me conclude that patterns of cortical activity may suggest the presence of awareness behavior in a few cases in which the neurological examination does not, and that they may also have some value in prognosis. But at the current level of study, they remain a research tool, and that is, they're not ready yet for clinical application. And what we need is better standardization, more experience using them to define the positive and negative predictive values, which we don't know. I mean, we just have a handful of patients now. And once that is done, and there's a general acceptance that these are valid, and when they are valid, we will then have them become useful clinically, but I believe that they will be. We need more detailed studies with greater numbers of patients. We need more reliable funding. This group of patients with disorders of consciousness comprises an orphan group, so-called, using a metaphor. That is, that there isn't funding directing at them. There is the way for some other illnesses where there are groups to try to raise money. And by these further studies, we'll be able to map the anatomy and physiology of human consciousness. I think we'll be revising the diagnostic criteria of vegetative state and minimally conscious state to incorporate these data, and that we'll want improved technology to allow these patients to communicate. So thank you very much again for the lovely introduction, and I hope to be able to answer questions if we have time.